I think the future is that amalgam is going to be phased out state by state, country by country. If only for the reason, what are we going to do with the mercury scrap? What, the stuff that we suction out. So the amalgam fillings you can get around with composite resins, and we're all hopeful that we're not going to find anything problem with that. Stainless steel crowns can be used on extensive fillings, but then there's the issue about what kind of stainless steel it is. Is there nickel in the stainless steel that's in the crowns? The last time I talked to Boyd Haley, he assured me that stainless steel crowns were okay. There's formicresol, which is used in partial nerve treatments, which is, I think, a big issue, which most people don't even consider because the layperson doesn't really know what we use. But that's a very strong medicament that we use to sterilize the remaining nerve after we do a partial nerve treatment. It's been used for years and years. A lot of pediatric dentists have wished that there was an alternative. Many have been proposed, many have been experimented with. Nothing is as good. But that's a problem because it does get into the peripheral circulation. So I'm definitely concerned about that. But not having a better alternative, maybe we'll have to extract a tooth that otherwise might have been saved and put in a space maintainer instead. The problem is space maintainers are made out of stainless steel. So, and if there's nickel in some stainless steel, we have to look into that. So there's difference between having concerns and having demonstrated problems. So if you know your child has all kinds of allergies, which 36% of our kids do, then we'll have to have a discussion with the pediatric dentist and the orthodontist, because we were talking about that previously. Tell them what your qualms are, and let's start breaking out and find out what's in this stuff. And then talk to the child's immunologist and put our heads together. What do you think we can do? And can we have a challenge? I don't know enough about immunology to know what constitutes a challenge. Can you use a very small amount? And if the child is okay, is it going to be okay when you're going to do several composite fillings and over long periods of time? Is enough? Is there anything that's going to leach out in any appreciable amount? I mean, what you're talking about is, very small amounts in neurotypical children. Even amalgams, you could argue, in neurotypical children and adults. We've used it for years and years, and there were no demonstrable problems. Given the epidemiological studies that we were using, which are probably not sensitive enough to tease out the subset that we're talking about. But we're not talking about neurotypical children. So this is an area where there's no solid science. Mainstream dentistry is not embrace this. So you need a pediatric dentist, a orthodontist who reasonably knowledgeable, at least has an open mind, and will go case by case. But typically, child comes in, we take a medical history. They're allergic to, let's say they were allergic to casein and gluten. They had asthma. They had pollen, but nothing beyond that. They didn't have fabric allergies. They didn't have multiple allergies. They didn't have eczema all over their our bodies. We would assume that the composite fillings would be okay, because we have not run into problems with composite fillings with anybody yet. But you have to take into consideration that amalgam was used over 100 years before anybody realized that mercury was an issue.
What about patients that come to you that maybe already have amalgam fillings? Do you suggest to those parents to replace them?
Well, we don't run into that in pediatric dentistry. You'd have to have a special situation where somebody was seen by somebody who was using amalgam fillings. Amalgam fillings in pediatric dentistry there's fewer and fewer dentists who are using them. And then the parents would turn around and say, we want to get them out, when the teeth may only be in their mouth for 2 or 3 years. Plus, how many parents want to go through that again? The trauma of it, plus the expensive. So in pediatric dentistry, we don't run into that problem. What I think what the American Dental Association would say is that you don't take them out. But if you're going to, when the time to replace them, to replace them with something else is perfectly fine. And then you've got the options of composites or some type of crowns, which is you can have an inert, non-precious metal, or porcelain, or a combination. If people do decide to take them out and can find a dentist who's willing to take out serviceable amalgam fillings, there is a greater risk in my mind of taking them out because the acute exposure to the mercury when you grind them and pulverize them and aerosol them. So there is a protocol out there, which if that was you would elect, if the patient elects to do it and the dentist is willing, I would follow the protocols that have been established to do that. That's usually there's some type of vitamin therapy or mineral therapy or detox therapy prior, and then certainly have a rubber dam so that the mercury doesn't, so the amalgam aerosol does not be absorbed by the mouth tissues. It's like a rubber piece of rubber that goes over the teeth that blocks the rest of the mouth, and high volume suction and oxygen, so the patient's breathing oxygen, not breathing in the aerosol created by taking out those fillings.
What's your opinion on sealants? Do you think there's more of a benefit versus risk for our children to have sealants, or do you think because of adding just more chemicals to children that are already having issues, maybe detoxing, you would not recommend
Well,
doing?
the problem is the sealants are basically the same material that's in the composite filling, except it's more flowable. So you can paint it on, where the fillings have to be they're thicker, so they're syringed in, and then they're compressed and shaped. So the material is virtually the same, very similar chemically. So these are very susceptible surfaces. The surfaces that the sealants cover, the biting surfaces, the 6-year molars and the 12-year molars, basically, very susceptible to a tooth decay. So statistically, our kids are probably going to get decay at the same rate that the neurotypical population is, which is very, very high. Like 85% of all 12-year molars decay by 17. So, and 6-year molars, I don't have the exact statistics, but it's very, very high by the time kids are 11 or 12. So I would say, again, depending on the medical history and just what the immunological status is. I mean, the more sensitive the children are to the more things, especially chemicals. That's been demonstrated. The more careful we have to be, the more we have to. It's incumbent to talk to the immunologist. Is there a way to challenge the child? And the one thing you do is when the sealant is dried with the ultraviolet light, the outside layer is inhibited by oxygen in the air, so it doesn't set hard. That should be wiped off, because right there you've got a non-inert, very active surface of chemicals that's going to touch the tongue and lips and everything like that. So to answer your question directly, I would consider sealing the teeth preventively, just like any other child, because the alternative is more the same. We use basically the same stuff, but it'll be much more traumatic and cost more.
How about nitrous oxide? I mean, there's some discussion in the biomedical community that certain polymorphisms like the MTHFR could cause those kids could have an adverse reaction. Have you ever seen that? And should parents be concerned about using nitrous oxide as a calming measure for
I just learned about it yesterday at this conference. I never heard of it. And I talked to one of Dr. Usman's nurse practitioners, who's a nurse anesthetist, and her feeling was it's very common in our community, and it's much more common than we ever thought in the general population. So her feeling is because it interferes with homocysteine metabolism, that it's just not a good idea. So personally, I stopped using nitrous oxide years ago because of the effects it had on male anesthesiologists' children. That was enough for me personally. So if I would not take the chance with my own children, I'm certainly not going to take the chance with anybody else's. So, and we can get around it. I mean, nitrous oxide is helpful, but there are ways around it. So I would say, given the information that I have gotten, I would want to err on the side of safety. But that's something that if children have to be sedated or put to sleep in a hospital or in a surgery center, definitely discuss that with the with the anesthesiologist, because nitrous oxide has been used for years and years and years, and it's just basic to what they do. They may not be aware of what this new information is, so I would share it with them for sure.